So I'm going to make a summary of this excellent symposium with superb speakers. We have learned from them that what we have learned from pathophysiology at any cell level that we might think in lupus, either the antigen-presenting cell, the T cell, the B cell, has allowed us to have a number of potential new targets to be directed towards for treating SLE. These same cells plus a variety of cytokines would allow us to have new therapies and moving into less ablative and more selective treatments that would do better for our patients. So we have now many advances in patient care, but we can do better. Pathophysiology insights have provided new treatment targets that might help us overcome our current treatment limitations. Immunosuppressants and steroid therapy must be reduced to avoid comorbidities, because we have all learned here that prednisone is the villain of the study, and improve long-term patient outcomes. And it is indeed possible to tailor therapy for every patient, despite the dreadful heterogeneity of the disease. So we have to shift our management from just responding to acute events to maintaining long-term remission. Because our favorite disease is changing rapidly, and the cumulative effects of these changes will be profound, both in patients and for us. And perhaps the greatest achievements, hopefully, are yet to come. With this, I thank you for your attention, and let's hope our two icons can coexist pacifically, both the wolf and the butterfly, in the near future. And I will now open the session for questions and answers. So this one's for, I believe it's for Michelle Petrie. Please comment on efficacy, safety, in dosing of, I don't understand the word, ACTAR in SLE. Similar, I'm sorry, but you have to do better than that, guys. If I cannot read it because of your writing. This is for Dr. Petrie again. Since hydroxychloroquine plays such an important preventive role, would you start it in patients who have subacute cutaneous lupus rash, but which are anti-DNA negative?
My view about hydroxychloroquine is that it's background therapy for everyone. It's certainly been proven to have benefit for subacute cutaneous lupus, but with all of our patients on hydroxychloroquine, we often have to add on top of it because it may not be sufficient for disease activity.
And which is the dose of vitamin D you use? That's for you too. Which dose of vitamin D do you use?
For vitamin D, we started at 50,000 units once a week. In some of my very obese patients, we couldn't hit 40 with 50,000 once a week, and they needed 50,000 international units twice a week.
And do you routinely measure vitamin D levels in lupus?
I now believe that I should, the same way I believe Natalie's data that we should be measuring hydroxychloroquine levels, because the levels are objective data that we can show to our patients to encourage adherence.
Why the plus minus 40 level that you mentioned?
Remember that our statistical modeling showed there's absolutely no benefit of getting above a 25 hydroxy vitamin D level of 40. You know, I can't explain that mechanistically. It's just a fact of the clinical analysis.
And Michelle, again, why not use the new approved synthetic glucocorticoids second and third generation with less side effects?
I'm sorry, but I have no experience with the newer corticosteroids. I would be absolutely amazed if they really can limit corticosteroid damage that much.
Oh, this was about Actar? Is that the question?
No, that there are long-acting corticosteroids developed for rheumatoid arthritis, for example.
And which kind of flare do you treat only with vitamin D plus hydroxychloroquine?
I would combine as many immunomodulators as possible, and though we didn't talk about DHEA, I still use DHEA in premenopausal women because it's another immunomodulator. So individualize, but use immunomodulators to try to reduce prednisone dependence.
I'm sorry, but they all seem directed to you. How would you recommend treating Ranauts and SLE patients if you avoid calcium channel blockers?
Thankfully, Raynaud's in lupus is less severe than in scleroderma. Rarely does it lead to digital gangrene or digital loss. I believe in some of the chemical packets that can be squeezed and stay warm for 4 to 5 hours. In the United States, we have 2. One is called Hot Hands, and the other is called Hot Snaps. By the way, it is difficult to give calcium channel blockers to young women with lupus who have a lowish blood pressure. So I don't use them very often in lupus, but of course I use them all the time in scleroderma.
And does vitamin D has a strong impact similar to that of Plaquenil on lupus?
Let me repeat the word modest. But hydroxychloroquine has a modest benefit on disease activity. If you combine enough modest things, they can add up to something that's clinically meaningful.
I don't have any more question cards. Does anybody wants to get to the microphone and make a question? I want to address a question for all the panel. When would you use the new biologics? When would you use belimumab? When would you use Rituximab? In which clinical conditions would you give it a try?
Let's go first.
Severe lupus, mild lupus, very serologically active. Which patients would you choose?
Well, it's a little premature to talk about Rituximab, but I can certainly address belimumab.
Yeah.
And I think each physician will have a different threshold for using belimumab. So right now, I am using belimumab in patients who continue to have active disease despite background therapy. So I may be trying to reduce the steroids. They may still have active disease despite being on immunosuppressives.
Okay. As an additive therapy, irrespective of serology? Or do you choose patients which are serologically
this came
active?
up yesterday. So certainly in my area, none of the insurers are asking to see SLE, nor are they asking to see laboratory results. So it's up to the physician pretty much. And I will use it based upon clinical activity and not so much serologic activity.
Anybody else from the panel has a different opinion?
I'm going to contrast that with the fact that I think the post hoc analyses are very informative, that it's going to have the greatest response in the patients that have low complement and anti-DNA, sort of doubly serologic active. And I'm going to go to those patients first if they have uncontrolled disease activity.
I think that's an excellent point. And then I would like to add that if you admit that antimalarials and things like vitamin D are a basic therapy that should be considered for all patients, then all the other treatments that we have today, the corticosteroids, of course, very clearly, but also the conventional immunosuppressives, are associated with toxicities and long-term results that are not favorable. So that, in fact, the balance between those therapies and the biologics, in as much as we now can speak of the biologics, because we're still trying to figure out which ones of them really do work, and there's only one approved, but we hope, of course, that the dust will settle, and maybe a few years from now we will all agree that there are 3 or 4 or 5 maybe biologics that are all effective in some situations, and then I think we will have to honestly say that these are actually better options than the conventional medications, but there's less experience, that's important. We do have certain specific side effect concerns. There's a convenience issue with parenteral therapies, and there's the big issue of cost. And we're struggling with the cost issue a lot, and that's totally legitimate. And I think some of us come from societies that do not have so much resources. Others have it better, but we are all struggling with it. I just do think it's extremely important that we keep that as a separate discussion, that we don't mix it up in our minds, and that we keep straight that, okay, if we all agree that the treatment A is better than B, and then we say, well, it's actually also very much more expensive, then we have to calculate it out. But we do have to be first in agreement on what is better for which patient.
Okay. Anybody else? Well, then I thank you very much, all of you. It's not common to have all of you in the same panel. Yes?
We have a question
Can I
there.
ask something?
I'm sorry? Go ahead.
Can we use belimumab after using rituximab?
So in fact, not only can you, I mean, you could do whatever you want, but it's interesting scientifically because any drug, be it cyclophosphamide, rituximab, that kills off B cells, you'll immediately see a rise in bliss levels. So it may be, in some ways, theoretically sound to follow up with belimumab, but there's always going to be caution as far as adverse events with that combination.
In fact, someone has suggested that they might have a synergic effect, blocking different pathways in B cells, but the concern was adverse event. Dr. Van Ballenhoven.
Yeah, so we have had a lot of negative experience combining two biologics, right? So in the RA setting, there have been several failed trials with that. With this particular combination, there is a rationale for trying it, and I do think that there is a trial being designed currently in the United States that will investigate exactly what you said, rituximab first, and then belimumab. Is there a safety concern? I just want to mention that there has been a very small trial where rituximab was followed by not belimumab, but atacicept, which is not the same, but it's somewhat similar. And although the trial wasn't positive in terms of efficacy, there was no safety signal. So it's certainly very much worth to look at. I think if I had a patient who had been on rituximab and I wanted to give them belimumab, which is now in fact happening, we do as a precaution say it has to have gone at least 6 months or so before we will start considering that.
Any more questions? Then again, I thank you for being here and your excellent lectures, and I thank you all for your attention. Have a good evening.